All right, good morning, everybody. This is the official start of this fourth managed care contracting training that is being sponsored by the Managed Care Technical Assistance Center. So I want to welcome you to that. And I say this is the official start because we kind of began maybe at 9:15, then realized some people got word that this started at 9:30, so we held off, and we know the weather. So there's lots of reasons why, hey, we're glad to be here. We're glad that you're here today, and hopefully you'll find this session helpful. My name is John Lee, and I'm with Coordinated Care Services. CCSI is actually one of the partners in the Managed Care Technical Assistance Center work. And again, officially, we're very pleased to have you here today to this training that will focus on managed care contracting with a special focus on managing that contract from and negotiating from a position of strength. So hopefully what you will hear today will be helpful in building that relationship with the managed care agencies and helping them to understand the value that you bring to their network. So we think that you should get a lot out of this. This is the fourth training on the same topic that we've had across New York State. We started in Rochester, been in Long Island, New York City, Albany today, and there will be one more down the road. You'll also notice that this is being recorded, so there will be a session available for folks to listen to if they weren't able to make it today. The feedback has been really, really positive. I have to say, in Rochester, about 85% of all the evaluations were completed with good feedback, but what was really striking that 85% of the folks that attended took the time to complete that evaluation. So it would be great if today, even though the numbers may not be quite as large, if everybody could take the time to complete that evaluation, whatever feedback you want to give. But we do want to use the information that we get back to improve the work that we're doing as a Managed Care Technical Assistance Center. I want to take, because we've gotten a request for a little bit more information about what is this Managed Care Technical Assistance Center, I'm going to take a couple of minutes to talk a little bit about the work of the Technical Assistance Center. But before I do that, I just want to introduce Dan Ferris, who's right in front of me. He's with the McSilver Institute, and the McSilver Institute out of NYU is actually the lead partner in the Managed Care Technical Assistance Center. And I'll keep saying that. We hear it referred to as MCTAC, which is really okay. We also hear it referred to as MCTAC. Either way, there is the acronym, and we will be grateful for you to mention it in any way that you can, because we do believe that this work will help providers prepare for the world of managed care. So the goal of the Managed Care Technical Assistance Center is to make sure that the providers across New York State are ready for Medicaid managed care, as we anticipate it will be come April 1 of next year for the city, and then October 1st of 2015 for the rest of the state. So what we're planning to provide, or continuing to provide, because the work has already begun, is education, training, learning collaboratives, a variety of vehicles for you to learn more about what will be helpful in building that relationship and having a successful agency in the world of Medicaid managed care. So anybody here, had you attended the kickoff meeting, one of the kickoff meetings for Managed Care Technical Assistance? Thank you. I'm seeing maybe 50%. That's great. So some of you, this is the first training that you've attended. How many of you actually completed a managed care readiness assessment? All right. And we've got maybe a third to a half of the folks that are here saying they did. The Managed Care Technical Assistant, the Managed Care Readiness tool is currently being evaluated to see what kinds of additional training that providers across the state will benefit from: mental health, substance use providers, those that provide both, those that currently don't really bill Medicaid because they're providing those services that are now referred to as home and community-based services. So we're really looking for that information as a vehicle to make sure that we are providing helpful information and in ways that you'll find will be valuable. Here are the partners for the Managed Care Technical Assistance Center. And you can see there's quite a few different organizations that are working together under the direction of the Mixover Institute to deliver a variety of programs. Again, April 1 tends to be a very, very important date. There'll be more trainings coming out. And the approach that we'll be taking, much like we're doing with the managed care contracting sessions, is to have the same session repeated multiple times across the state, but also have it recorded and do some follow-up. Each will really be dependent upon the type of training and what we think is going to really be most helpful. Also, what you'll see happening is the Managed Care Technical Assistance Center will be serving as a clearinghouse for other kinds of trainings. We're working with the Health Plan of the Health Plan Association of New York State to really understand what kind of training they believe is appropriate, and hopefully we'll be able to coordinate that in a way that will make sure that the resources that you're devoting to this readiness work will be well used. So we've talked about the kickoff meetings, we've talked about the readiness assessment, and we've talked about the various types of training, both informational like the one we're having today, as well as intensive training services. And again, some of that may be the creation of learning collaborators, which are really going to be driven by understanding the needs of the various providers and bringing folks that have similar needs together. It would be helpful for you to give a thought to how you will use this information within your agency. And certainly as we share information about readiness, we also are encouraging agencies to think about building a project team that will support managed care readiness, executive leadership, finance, clinical leadership, evaluation folks. Even if you completed the readiness assessment, we're hoping that you actually did that as a team, because taking the time to look at those questions and understanding what the collective understanding is of your agency can be very, very helpful. So as you get this information, it really makes sense that you find ways to share it more broadly, encourage others to either attend these sessions, others from your leadership team to attend the sessions, or to view the recorded sessions. But the investment of time, we really do believe, is going to pay off in your ability to deliver services that will have a positive impact on our clients, our peers, that will actually demonstrate value to the managed care organizations. We talked about the managed care contracting unit, and that we've done this is the fourth session. Also, plan on attending a plan perspective session that will be held on December 17th at 2:30. You can register for that by going out to MCTAC.org. Again, it will give any providers the opportunity to hear from an attorney representing the plan on how they view the contracting process. There'll also be provider and policy perspectives forums in January. Again, these will be webinar-based so that you don't have to travel, worry about the weather in order to get there. We're also expecting for the contracting session to have some office hours, so that if you are moving forward with a contract negotiation and you have some questions, you can actually call through this webinar and raise those questions and hopefully have a dialogue amongst providers, or also get some information. This is the first technical assistance topic, but what you will see happening down the road is announcements for topics around finance and billing, including revenue cycle management, utilization management, a critical feature in the relationship between a managed care organization and a provider, and also around outcomes. How do you work to really demonstrate value, the quality and cost proposition in your relationship with the managed care organizations? So that's a little bit of background about the work of the Managed Care Technical Assistance Center. You see here and in your handout that there is a link for you to go to if you want to get more information, or if you have questions or feedback. Please feel free to let us know. Again, this is only going to work if we're really conscious of the needs of the providers across the state and developing programs and educational opportunities for you all. So, having said that, now I have the pleasure of introducing Adam Falcone, who is the speaker. And Adam is an attorney with Feldsman, Tucker, Leifer, Fidel out of Washington, D.C. And we're really pleased that he's a part of this work because he does have a lot of experience in managed care contracting. For the most part, he has represented providers in these negotiations. He's also represented nonprofit managed care organizations. So there's values related to those negotiations. How do you achieve the best outcome? And he's also done quite a few trainings on managed care contracting. So he comes to us with a lot of experience in the field and experience in teaching on these topics. So we're really very pleased that he was able to join us. And again, the feedback on his sessions have been really positive. And what you will hear from him today is really managed care contracting within the context of the request for qualifications for behavioral health benefits administration that has been issued to all of the managed care organizations. That's really the guiding document for the managed care companies. That defines what the state's expectations are. So as he shares with you his perspective, he'll do it within that context, and hopefully you'll find that that's very, very helpful. So again, thanks for being here today. Safe travels on the return, and here's Adam.
Thank you, John, and thank you to the McSilver Institute and CCSI for hosting these trainings. You are so lucky to be having this kind of support from the state of New York. Your peers in other states are envious that they didn't have this kind of support when they moved to a Medicaid managed care system. And so I know that some of you are already contracting with managed care companies and wish you got this training even earlier, but it is a tremendous resource for you, and it's really good that you've taken advantage of these resources. When I was back in grad school and started going over to the public health school as I was in law school, I almost got whiplash going back and forth because the teaching philosophies are so different. Any of you who have ever seen how lawyers are trained, we're trained to think very narrowly and within a confined sort of box. In the School of Public Health, there's a big world, outside of the box types of thinking. And I took a course there involving population health, where we talked about how you identify risk populations at risk in communities, design interventions to address those risks, and then, of course, what do? Measure the impact of those interventions. And one of the books in those courses dealt with the similarities between managed care and population health management, and said that basically it's the same sorts of activities. One, you're doing it for the public at large, and then in managed care, you're doing it for a defined population. And that's really true. The best managed care companies adopt the philosophy of population health, and they see a critical role in supporting the providers because they know that they have value to add to the equation. I'm not saying that all managed care companies adopt that philosophy, but there are some. And those are the companies that you really want to partner with because they're willing to invest the resources because you're on the same page as them. They have a limited budget to deal with. They have to identify where to spend those dollars. Denying individual services isn't really going to get them very far, but actually looking at patients, those that are really sick, those that really have those additional comorbidities, that's where the dollar savings are. In fact, your patient populations, where individuals who have behavioral health conditions as well as comorbid chronic health conditions, cost the system 60 to 75% more than individuals with chronic conditions alone, and if they have addictions issues, it's estimated up to 3 times. So think about the dollar savings that these plans can achieve now that they're integrated. You have the mainstream plans, you have the heart plans. Those resources are together, behavioral health and physical health for the first time. And your patients who they feel may be not getting all the physical health services they need, if there's a way to manage those costs, there's a huge dividend in savings for them. So part of the training today is to make sure that you don't get the impression that the big bad managed care companies are out there and they're here to harm you. That's not necessarily the case. They can be a forceful advocate and partner in pursuing population health initiatives, and partnering with them and understanding them will serve you in the long run. First, a disclaimer, since I am a lawyer. My law firm told me I had to have this slide. I'm not licensed to practice law in New York State. I'm not an employee or contractor with the Department of Health. I don't work for the Department of Health in that capacity. I'm not an employee of the McSilver Institute. And this training is for educational purposes, not for the purpose of legal advice. How many of you are familiar with Malcolm Gladwell's book, David and Goliath? Kind of got panned in the media. So yeah, a few hands I see. Well, he tells a really interesting story and sort of perspective on David and Goliath. He says, the common understanding of that story is really about David the underdog, where he was a shepherd boy, and he was able to fell this huge giant with basically just a slingshot. And he says that, in today's contemporary culture, we look at the story of David and Goliath, that David really is just this underdog. And it is improbable for a David to ever win any sort of battle with a huge giant Goliath. And he says that we have it all wrong. He says that, the big giant, Goliath, he was in all this armor that made it hard for him to maneuver and walk. David had this slingshot, and the power and force of the stone on that slingshot was so powerful it was equivalent to a gunshot. And it was so precise from many feet and meters away, it was so accurate. So it was not a surprise that when, they came kind of together, and David was able to swing his slingshot, strike him in the middle of the head, and then cut off his head. And prevail, because he had advantages that Goliath didn't have. So part of this training I want to talk about and emphasize is that you have certain advantages, despite your small size, and how you think of yourselves vis-a-vis the managed care companies. I think David and Goliath would look at, Malcolm Gladwell would look at this slide and say, it's not the giant who has the advantage. It's not the big guy. Yes, he's strong, and those bring a certain amount of value, of advantages to the table, but the little guy has advantages too. He's much more nimble. He can offset perhaps the giant's weight and balance him, the big guy's weight, and win in a battle. But the smaller one just has to know about those advantages and know how to prevail and use those advantages to his or her advantage. So today's session, I want to accomplish a few things. First, I want to give you a plan for how to approach managed care contracting. I want to have you start thinking about how you add value to the managed care plans. We don't look at the plans typically as a customer, but they're going to be paying you. Those are customers, and how you can add value to them. Thinking about how you strategize in negotiations to achieve an agreement that both parties are happy with. What arguments you might want to use in negotiating contracts with managed care companies. A team-based approach internally, so you can use your resources best. And then the meaning of common provisions, as well as what favorable and unfavorable contract language is. So my first job in Washington, D.C. was working for a small organization called the U.S. Department of Justice. And I worked in the antitrust division at the time where they had a healthcare task force, which was a creation of the Clinton-Reno administration. In fact, at the time, the antitrust division was prosecuting Microsoft, and those attorneys were working upstairs for me. And I always felt sorry for them because, when they came in the office in the morning, the first thing they did was boot up their computer. What image do you think hit them in the face? Microsoft's emblem, logo. But in the antitrust division, even though I had a public health background, I started to look at the world and the healthcare markets sort of from an economic, financial, antitrust perspective. And your managed care contracting has two parties, a buyer and a seller. And we look at the big managed care company as with great purchasing power as the buyer, and then you often feel like the smaller provider. And our healthcare system is fundamentally flawed. This market doesn't work. And the reason why it doesn't work is because in this marketplace, it's not you, the provider, who are setting the fees and establishing how you get paid. It's your customer. They're telling you how much they're going to pay you and in what kind of methodology. It's no wonder that our payment system doesn't support patient-centered clinical patient care, because it's designed by a payer to be the most efficient way to pay claims. Think about it if you walked into a restaurant, looked over a menu, identified maybe not just one, but 2 or 3 items on that menu that you wanted to have. The waiter comes by to take your order, and you say, I don't want just one, I'll take 3 of these for $50. What would his reaction be? They'd laugh, yeah, they'd laugh at you. You don't get to decide that, you're the customer. We tell you how we're going to deliver these services to you. We tell you how we want to price these services to you and what those prices are. In healthcare, it's exactly the reverse, where the payers are dictating all those types of things to you, the provider. That doesn't work. That doesn't work because it doesn't have the payment system support what you do in a way that's a logical, sensical way. The system now, as many people have said, just supports increasing volume and not the value for services. So what we'd like to see and try to attain is to try to level the playing field. And the training today is to try to equip you with the arguments, the power, the philosophy for how you might anticipate how you could contribute value and level the playing field by increasing the leverage you have in those discussions, so that it's not a huge David and Goliath situation, but it's more one-on-one. So before I dive in too far, I want to talk about the fact that our system is not as simple as it may be made out to be. There can be a lot of people between the person buying health care coverage and you, the provider. In many cases, the Medicare, the federal program, Medicaid, employers, they purchase health coverage benefits for their employees from managed care companies. Those managed care companies don't always directly contract with providers, but instead go to intermediaries, ACOs, BHOs, IPAs, you name it, some acronym of an alphabet of some group of providers working together, and then those networks contract with providers. But even if you contract through an IPA, even if, maybe not even not today, but in the future, you join a PPS or an IPA and they are contracting with an HMO, you still will have to have a contract with that IPA. And all the issues that we talk about today, all the issues that relate to these contracts will be in those same contracts that you have with a network. So this is relevant to you whether you contract directly or indirectly. And why should you care? You may think about the most important thing being these reimbursement rates in the contract. And you may know that in New York, you're guaranteed your reimbursement rates under the Medicaid fee-for-service program in these managed care contracts for the first 2 years. So you may feel, we're in a relatively good position, we don't have to worry about these contracts too much. But that forgets everything else in these contracts. The fact that it defines what scope of services you're going to be paid for, what's covered under the benefit plan, whether you can subcontract to practitioners or other contractors to carry out part of your activities, how the credentialing process works. If you don't have a credentialed provider and they provide care to a managed care company, you're not entitled to payment. Access and quality standards, appointment waiting times, how long people can wait in waiting rooms, but also how quickly people can get in to receive services that you provide, all dictated under the managed care contracts. Utilization management, whether services are approved. Regulatory penalties, if the plan is assessed, sometimes the plan will then go back to the providers and fine you some pro rata amount. Whether you can waive co-insurance, cost-sharing obligations. Many of you have charity care policies for people who can't afford services, whether you can apply them in the context of managed care. Prompt payment, how soon you are entitled to receive payment after you submit the claims. Whether the plans can suspend payments to you if they have an allegation of fraud. Whether they can recoup overpayments. Do you know that in the RFQ that was published by New York State, the plans have up to 6 years to recoup payments from you if they determine that they overpaid you? 6 years. I don't think any CFO is going to be too happy with that after they close out the books on a particular year. Retroactive disenrollment. State decides that somebody is no longer eligible or wasn't eligible 6 months ago. Plan takes the money back that they paid you. Appeals, when you have inevitable disputes with the plan. Dispute resolution, all products clauses, commercial, Medicaid, Medicare, what the payer is offering. Term and termination, breach and cure, post-termination responsibilities, amendments. It's a long list in governing law. So even though you have it really good with rates, at least on the Medicaid side, for 2 years, all these other provisions will actually impact whether you get paid and whether you're getting paid enough because of all these other issues that you have to contend with that you don't have in the fee-for-service environment. Think about how easy it is really in the Medicaid fee-for-service program. You fill out your provider application or your agreement, you're in. You submit claims, you get paid. There's not much in terms of utilization review. It's very simple. Everybody can participate in a Medicaid fee-for-service environment. In a plan world, in most cases, the plans decide what providers they want to contract with, and they can leave people out. Again, there's some protections in New York for the first couple of years, but after that, they don't have to contract with every provider for service. They get to choose. So let's talk about contracting strategy. And by the way, if you do have questions along the way, don't hesitate to raise your hand. I'm happy to take questions as we go. If I use an acronym or a phrase that you're not familiar with, if I mumble over a phrase, anything at all, feel free to stop me. So I think lots of times we'd be happy if you could just press a button and the negotiation would be done. Because, frankly, I find Americans don't like to negotiate. We don't like to go into that to buy a car and have to negotiate. Many of us liked that there was just a single price by one of those car companies and we didn't have to do that anymore. We like that we can go into a grocery shop and just see the price and know what we get paid. We like to compare prices online, but we don't actually like to negotiate. It feels uncomfortable to us. It feels adversarial to us. People are disinclined for that kind of a process. I think some people in other countries who do that more regularly are much more comfortable with negotiation. But in our country, we're not so comfortable with it generally. So here's a strategy, somewhat corny, to think about. And I want you to think about it before you sign those managed care contracts. And it breaks down into 3 parts. First is the part of preparation, the most important phase, and I'm going to go into quite some detail there. The second part is evaluating the contract, what you're looking for. And the third part is negotiation and how you might think about doing that in a more effective method. So let's start with preparation, which is the most important phase, where you actually think about what advantages or what leverage you might have. A few weeks ago, I was in a discussion with a state behavioral health director on behalf of a state behavioral health association. And they are sort of like in this dispute with this department because the department had this initiative that they wanted to move forward with that would completely revise the contracts that they had with behavioral health and addiction providers. And the addiction providers and substance abuse providers and behavioral health providers, they were not crazy about this. And we had a short list of changes that we wanted to the agreement. And we went in to meet with the director. And after we presented the changes we want, he looked at his general counsel and he said, do it. What we didn't realize was that we had enormous leverage in those discussions and probably could have asked for anything. Because this initiative was the single most important initiative to this department director. This was his legacy. And he was going to leave in January because a new administration was coming in, and he did not want to leave without this being done. We could have asked for anything, and he would have made it happen. But we did not know how much leverage that we had actually in those discussions before we started arguing. That was a complete mistake, an utter mistake on our part. If you know how much leverage you have, it completely changes how you approach negotiations and how much you ask for, how much you think you can ask for, and how much you're going to obtain in return. As you think about managed care discussions, negotiations, and leverage, it's not an isolated event. I'm going to talk through a couple of phases where you identify what leverage you have and assess your leverage, thinking about what value you can add if you can compete based on value and obtain some additional leverage. But you won't be happy. You probably will think to yourself, I don't have as much leverage as I want today. I can't compete on value the way I really would like to today. So in the future, you may have to think about how can I change those dynamics so that you do have more leverage. Maybe not today, but maybe in a year from now. Or you can compete on value, maybe not today, but maybe 2 years from now, so that you have the leverage that you want to have in those discussions. Yes, question? So the question was, wouldn't it be helpful if MCTAC, MCTAC, whatever you want to say, reviewed the contracts, the managed care contracts that they were offering to providers, because there's resources there. I think it's an idea, but it probably won't work. And the reason is because the whole point of these contracts are to give plans the flexibility that they need to design their own program. They want them to compete. They want them to do things differently. And I know we look at contracts right now in a fee-for-service way, which is probably too limited. But in the future, there's going to be a lot more alternative fee arrangements with shared savings. There's going to be networks of providers that come together. There's going to be many of you who, if you haven't partnered yet with primary care providers, will partner with them. Many of you will join PPSs under the DSRIP program here in New York. And so it can't be viewed in just an isolated event. The other aspect is that, under the antitrust laws, you're all viewed as separate independent providers and have to come to independent decision making. Now, that said, I'm going to talk about later, about how you can work together, because there are some permissible ways. It may not be everybody in the room, but there are some ways that you can join forces and sort of spread the costs among a larger group for having that intel. So I'm going to come back to that, so thank you for that question. So let's start with the first phase of assessing leverage. The ultimate question is, does the MCO have to offer you a contract? Fortunately, you have some good language in the RFQ, but you may not have that in every contract that's provided to you. In the commercial sector, if they offer you a commercial contract, they may not have to contract with you on that product. You might not mind that, since the commercial rates seem to be lower than the Medicaid rates here in New York, but they can pick and choose. If you're presented with a contract and they have to contract with you, think about the amount of leverage you have in those discussions. They can't walk away. They have to offer you a reasonable contract. They can't leave you out. In the District of Columbia, in the contracts between the plans and the state, the Medicaid agency actually identified by name 15 safety net providers and said that to the plans, you must contract with all these agencies, all these entities. The associations that advocated to have those specifically named safety net providers in the contract did their providers a huge favor. They created leverage in the discussions with the managed care entities that they would not have had individually. The plans could have just played them off of each other. So whenever you're approached with a managed care contract, I want you to think about, do they have to contract me? And look at your state law, look at the RFQ, if that's the applicable document, look at Medicaid or Medicare regulations. New York State's looking at new network adequacy requirements in the commercial sector. See whether the plan has to contract with you. And if they do, then you have additional leverage you should take into consideration. Under the RFQ, which if you haven't read it and pulled it down, you should. It's going to be available, I think, as a link even also on the MCTAC website. It's a long document, and yeah, you might have a bunch of tabs on it like I do for the relevant pieces, but one of the most important sections is Section 3 in that contract, where it reviews the types of providers and types of services that the plans must contract with. And you see some good news. If you're an OMH or OASAS certified or licensed facility, they must contract with all of you for the first 24 months if you've been serving 5 or more Medicaid enrollees. That's terrific news. But after that, after those 24 months, they don't have to contract with all of you. It's a different standard that applies. Just 2 of you per county. So look through this list. This is an abbreviated list on the slide, but look through this list, see what services you provide, and see what the obligations are of the plan. The next question is, how much do they have to pay you? And here, too, there's good language for you, because in New York, they have to pay you, for certain providers, for the first 24 months, your Medicaid fee-for-service rates, no less than your Medicaid fee-for-service rates. So they can pay you more if they want to. And this is another question you should ask yourself, is that payment rate, and what are their obligations? If they have to contract with you and they have to pay you, you have an increased amount of leverage in those negotiations with that plan. You should know it right off the top. Here again is the abbreviated list. You should look it over and see what the rates are, what kinds of rates they have to pay you. If you're a residential program, how they have to pay you on a single or contracted basis. If you have an integrated license, when that becomes available, they have to contract with you for the full range of services. They can't cut and paste. They can't choose what services they want and which they don't. Yes, question? From the effective date, not of the. I know this deadline kind of moved back a little bit. It's when it actually begins. The term when they start assigning patients to the plans and then they start coming to you. That's when it's effective. The real kickoff date. Many of you know that the New York Health Plan Association sent a letter to the DOJ and the FTC recently because they're very concerned about the performing provider systems, the DSRIP program here in New York. Very concerned. Because they know if there's a single PPS in a region and they have to contract with that PPS, there's no one else to go to. The PPS can name its rates. The same leverage that small community hospitals have, sole community hospitals have in rural areas, where they can basically name their price. They have to be in the contract. They have to be in the network in order for the plan to meet their network adequacy requirements. Those hospitals, and here in this case the plans fear these PPSs, will have the enormous price ability to name whatever price they want And the plans are concerned that, of course, will raise their costs and then in turn raise premiums, and it will be anti-competitive. So they went to the DOJ and the FTC, they wrote a letter, they met with them in person, and they want them to intervene to try to prevent this from happening. So you should also make the same evaluation. Do you have competitors in your county or your area? How many of them are there? 2? 3, 4, 5? Have you ever done a market analysis to figure out who you will actually be competing with in the event in a managed care environment the plan has choices and can play you off of other folks? Or are you the sole provider of services in your county? And you can ask for what prices you want as well because the plan has no choice but to include you. Do you have that market power? The other question is, can they afford to leave you out? CVS, Rite Aid, Walgreens, can you imagine any managed care plan not including one of these pharmacies in their network? Who would sign up for them if they couldn't go to one of these pharmacies to receive their pharmacy services? These pharmacies, these huge pharmacies, have enormous market power and ability to obtain a favorable price. And it's not just in pharmacy services. If you look out in other communities across the country, there are providers that are so important to the plans, to patients really, because they want to be able to access services from those providers. They can't be left out. I split my time between Washington, D.C. and Pittsburgh. And anybody who's familiar with Pittsburgh knows that there's a very dominant healthcare provider called UPMC, the University of Pittsburgh Medical Center. It is the dominant hospital system. Highmark is the Blue Cross Blue Shield plan. That's the dominant insurer. And they've been at each other's throats for years. Why? Because UPMC has market power. And they can name their price, and Highmark is always annoyed. They think they're paying too much for those hospital services. Well, what did Highmark eventually do? They bought the second struggling tier hospital. The smaller hospital that had always competed against UPMC, they bought them. So now it's a vertically integrated system, a plan that owns a provider system. You don't see that too often. You see providers that became plans. And some of my clients, in fact, they were a provider, and they had an opportunity to create a managed care plan, and they did that. But you don't usually see it in the other direction, plans becoming providers. So how did UPMC respond? They said they're going to terminate their contracts as of January 1st with Highmark. Basically, Highmark members will no longer have access to any UPMC facility for care. They are banking on the fact that people in Pittsburgh won't tolerate that they will want to access UPMC for their health care, or know, at least in the back of their mind, should they get sick, they can go to UPMC. And now UPMC is contracting with other insurers and hoping that people move to those other insurers. It's a bit of a gamble, and we'll have to see what happens. It's not the only place this happens. It happened in Boston, where I used to live. MGH, Mass General Hospital, and the Brigham and Women's are under a partners healthcare system. They were in a dispute with Tufts Health Plan, and Tufts said, we may just exclude you from our network if we can't agree upon rates. And they went back and forth, and eventually they found a middle ground, and they agreed. But Tufts also was facing the prospect of maybe we won't have in-network services at any of the partners hospitals. And what will the effect be on our membership? Will we lose customers, employers, and other patients who no longer will choose a Tufts product? So how much recognition do you have in your marketplace? Does your community know you? Do they think about where they're accessing services, and would they join a plan if it didn't include you in their network? You probably have physicians or hospitals that you might want to go to when you think about purchasing your health care coverage. In fact, the government always suggests that Medicare beneficiaries, when they're choosing Medicare Advantage plans, look to see whether their doctor is in the plan. That's how many patients make a decision about a plan. They look at their current doctors, and they make sure that they're in the plan. Under Medicare Part D, they look at their drugs, and they see whether those drugs are in the lowest cost tier of the plan. That's how people make decisions. The third aspect is timing. Whether you have leverage because the HMO or MCO is shoring up its provider network to meet new network adequacy requirements, or maybe even is a brand new plan and doesn't have an adequate network right now. So there's lots of changes going on, even with the managed care plans, behavioral health plans here in New York State. And the requirements have changed in the RFQ for network adequacy, so there's a lot of fluctuation going on about shoring up their networks. Many of you might have seen the report that came out yesterday from the Office of Inspector General at HHS from Washington, D.C. The OIG had these people call up, posing as patients, to obtain access to services from Medicaid managed care providers across the country. And what did they find? 50% of the time, they couldn't get an appointment from the providers that were listed on the managed care websites as a participating provider in the plan. In some cases, they would have to wait 2 months. The OIG said this doesn't meet the network adequacy requirements. If you can't get into see the provider, then it's not much of a plan. So there's going to be renewed attention on network adequacy. The OIG told CMS, you better increase your surveillance of these issues. So there's probably going to be pressure on CMS, and you know how things work downstream. There's going to be pressure on states that run Medicaid managed care programs to conduct more oversight and monitoring activities of the plans to make sure the providers listed in their plans really continue to be the participating providers so that patients have access to services. Yes, question?
How can providers who are in communities that know of those circumstances get that information to the reviewers? New York ranks very low in taking action against plans for their network inadequacies. And so how can that information, which we know exists, those circumstances which exist, but there's no feedback loop, or the feedback loop is very lagged.
So the question is, how can we provide information to New York State so they could take some action against plans through that are not meeting their network adequacy requirements because providers aren't participating that are listed on their website, or they've left, or they've died, or they've moved on. But the most important part of your question actually came at the end about the feedback mechanism. How do the plans know whether a provider or practitioner leaves your organization? How do they know when your organization's reached its capacity and you no longer can take new patients? It's because of you. You're the only ones that can provide that information to the plans. And in all these managed care agreements, you have a contractual obligation to notify the plans if you're at capacity or a practitioner leaves so that they can remove them from their website. But that doesn't happen very often. The feedback mechanism loop isn't there, so the plans don't know about it, so they can't really do anything about it, and then upstream, the department can't do anything about it as well. The system doesn't work. That process does not work effectively. So it's going to take the collaborative efforts of not just the plans, but also the providers to find a way to do this that's efficient and timely. I do think that you should notify the department because they'll be increasingly looking at it, and maybe they will increase their oversight of the plans and ask them to do more. But at the end of the day, it's going to come back to you as the provider to informing the plans when you're at capacity or a practitioner leaves. Maybe there's an automated way that you can work with a plan to do that better, because the plans will get dinged for it. There may be a regulatory penalty imposed upon them, and then they might downstream that penalty to you because you didn't notify them in a timely way. So that's no good at the end of the day. Then you just get the short end of the stick. Thank you for that question. So when you're thinking about negotiating, timing is an important point of the discussion. Think back to when you've negotiated salary for a job and ask yourself, where did I have the most leverage in those discussions? Was it when I was thinking about joining a new employer and had to negotiate a salary that I would start with? Or is it when I asked for a raise or I have a performance review each year with my current employer and I wanted a bump in my salary? I think most of you would say it's when I would start a new job. That's when I have the most leverage in obtaining the salary I want. In fact, many folks that do move from job to job, they do it precisely because they get a bump in revenue, a bump in salary each time they jump to a new employer. And why is that? It's because the choice for the employer at that point, when you are applying for a position, is if they want you, they're going to have to pay you enough to leave your current employment and join them. You're going to walk if you don't get paid enough. But when you ask for a raise, you're not threatening your boss that you're going to leave if they don't give you that bump, right? You're not walking into those discussions and saying, I'd like a raise, and if you don't give this to me, I'm going to bolt. No, you kind of are saying you'll live with it because you don't have an alternative. You don't usually have a second job lined up where you can say, I get a better salary someplace else. And so you don't have leverage in those discussions. You really are asking for a raise because they don't have to give it to you. You're not entitled to it, and you don't have much power in those discussions. The same thing is true in the managed care discussions. When plans are building their network at the very beginning, you have enormous leverage because you can walk away. And when plans are starting to trying to meet their network adequacy requirements, because the state is about to do a readiness review to see whether their networks are sufficient, and the state may only do it once at the beginning, that's when they need you the most. So in our experience, when the plans have been running around like crazy, trying to contract with folks, this is where the providers have the biggest say in how those contracts look. So even though you are guaranteed reimbursement rates, do not miss this opportunity to get the best contract you can, because it may be the only opportunity you have for the next 2 or 3 years. This is an enormous PowerPoint for providers. You should know when the state is reviewing the network adequacy requirements of the plan, when they're conducting their readiness review, because when is that information have to get to the state? You know, I know in these discussions, plans might come to you and say, we need this signed contract back in 24 hours or by the end of the week. Do they really? Is it really the end of the week when they have to prove to the state they have an adequate network? Or is it really 2 months from now or a month from now, and they're just trying to, have a business plan, basically for project management purposes, they need to have they set these internal deadlines. Because honestly, 24 hours, 48 hours, that's not enough time to review a contract. It's not enough time to do the types of activities we're going to be talking about today. Just like you would feel pressure if you went to a store and the salesman said, this offer's only good for today. Most of us not only would be annoyed and not want to take that offer, but wouldn't like the whole approach of a only limited time offer, because we don't want to be rushed to make an important decision like buying a car or buying another high-priced product. Any of you who've sat through those god-awful timeshare types of presentations where they try to sell you a timeshare someplace and the offer's only good for today. I sat through one of those during my honeymoon in Hawaii. Not such a great idea. Lost a lot of time. My spouse was not too pleased about that. And it was frustrating. Even as a lawyer, I found the whole discussion frustrating. This is only good for today. You don't want to be in that kind of environment. And sometimes some of these time frames, these deadlines that the plans serve, sometimes they have sometimes they really do mean it. Sometimes they don't. I've seen these deadlines pass in some cases. The provider signs the following week. Any harm done? No. So be aware of what the plan's actual deadlines are to submit their documents to the state to prove that you are part of their network, to meet their network adequacy requirements. The more knowledge you have, the much better position you'll be to ask for a delay or an extension. And certainly ask for it. The worst they can say is no, but sometimes they'll say yes, and you won't even have to pitch a fit. After you think about the leverage you might have in those discussions and may be satisfied or may not be, some of you are thinking about the changes in healthcare services today and how the world is changing and trying to promote value-based payments. You hear it everywhere. You read about it everywhere. And you're probably thinking to yourself, how can I compete on the value that I provide? Well, we've never had to think that way as providers, because most of the time the fee-for-service program, the Medicaid program, signed us all up. And now we compete against our peers. Now we compete against those people who are also doing God's work and helping our patients? This doesn't make any sense. But from a market perspective, and that's what this system is, it does make sense. So this exercise is to try to encourage you to think about how you identify the value you bring to the table, assess how much value that is, and how you communicate that value to a plan. So that not only does a plan want to contract with you and maybe contracts with you and not John shop down the street, but maybe they'll pay you more because you're actually a better value to them, and you provide more value than John shop down the street. A much better argument to make. So let me talk about that. There's a professor at Harvard Business School, Michael Porter, who's written a number of articles and books on value. In fact, his argument is that you can link the perspectives of payers and providers around a value agenda, because that is going to be the most truly transformative strategy in healthcare, in his view. In his view, that will deal with all the problems you see in healthcare as if it's a value-based market and not the market that we have today. So he advocates organizing providers into systems of these integrated practice units where patients with similar conditions are dealt with providers around those conditions. He points to examples in Germany where they have a headache clinic, where patients who have headaches go to this particular kind of clinic, and the clinic worries about having the right type and mix of practitioners that deal with that condition. He points to our heart hospitals or our cancer centers. If you have one of those conditions, you know automatically you should go to one of those places because they serve your interests. In this regard, I think behavioral health and addiction providers are way ahead of the rest of the community, because you do focus on a certain set of conditions, and patients know, oh, if I have this condition, I should go to this kind of place because they'll help me get well, and they'll figure out the right mix of providers. But you don't have that a lot in primary care. Think about your primary care physician. You go to them, they may see you and you're relatively healthy, and the next patient could have 2 or 3 chronic conditions. He says that's a terrible thing in our healthcare marketplace. He says that's terrible for the doc because people who have chronic conditions, multiple chronic conditions, need a whole set of different resources and team-based care than you might do if you're relatively healthy and you come in for a visit. They may need to spend more than that 7 minutes with that patient who has multiple chronic conditions, but the system isn't structured that way. He says patients who share similarities in demographics, the language they can speak, who face similar barriers to care, they should be grouped together. So he sees a world where you change the system so that providers are organized around patients' needs. I think the same would be true in any professional services discipline, where people are organized by their level of expertise or area of expertise. I see the same fault at my law firm, where different lawyers have different types of expertise that they announced: antitrust, tax, litigation. But how do you know whether you need a litigator or an antitrust lawyer or a fraud lawyer or a tax lawyer? You don't. So this isn't very helpful knowledge to you when you're trying to choose a lawyer, because you have a certain type of issue and you're looking for a lawyer who can help you with that issue. So the legal industry is just as at fault as the medical system is arranged and set up. Porter also talks about having outcomes, measuring outcomes and costs for every patient, and not just the specific type of patient for their need, but the total cost of care related to taking care of that patient. How many of you are actually aware of the cost for your patient, the other cost of the patient, for the services that you don't provide? The hospital services, the physical health services, do you have any idea? Probably not. That information isn't fed to you automatically. In fact, these ACOs that started, the Medicare ACOs, the one thing that they demanded to have up front at the start of their program, access to data, because they wanted to run the data analytics to identify those patients at risk for higher costs so they could target their resources at them. Without that information, they can't do any of their targeted interventions. It doesn't work. But we as providers, we don't have access to the total cost of care. Many of us don't even know when our patients go into the hospital or an ER visit. And particularly if it's non-behavioral health, we probably have even less information related to that patient. He suggests moving to bundled payments for the total care cycle, either on a per member per month basis based on, for that patient, based on a diagnosis. Some states have come up with paying a set rate for a diagnosis of depression. Can you imagine that? A fixed price for all the patient's services and needs for depression. Lots of providers question whether that's really possible. But you know what? A lot of providers aren't actually asking them the question of, how do I want to sell my services? If you want a very interesting discussion to take place with your senior management team, get a whiteboard and ask yourself to come up with a perfect payment model for how you would like to be paid. Many of you have not gone through that exercise because we've been price takers. We've just accepted the payment methodology from the plans that have been made to us. Porter points to these examples. I think Lowe's negotiated an agreement with the Cleveland Clinic for a fixed price for heart bypass surgery. And so they'll actually fly employees, cover all their housing costs, co-insurance obligations for when they have heart surgery at Cleveland Clinic, because Cleveland Clinic has guaranteed their price. If there are further complications down the line, readmissions, Cleveland Clinic eats those costs. The Geisinger Health System has similar approaches, a fixed cost for a particular kind of service, guaranteed. He said there should be more of that, so providers actually have some of the business risk, not insurance risk, but actually business risk, so that if they're saying we can solve a patient's problem in X, they're guaranteeing a price for all the costs that might occur. And if they don't do such a good job in providing those services, then they have losses. But if they do a really good job and are creative and innovative and deal with those patients' needs and prevent further costs, then they reap the benefits. He talks about integrating care. Right now, you move from place to place. It's one of the most frustrating things as a patient. I go over here to see one doctor, then I have to go to this place to get a scan, and then I have to go here for the pharmacy. One-stop shopping doesn't really exist in the American healthcare system except for a few facilities like FQHCs, health centers, where you see some of them all under the same roof. Some of the Kaiser Permanente facilities, all the facilities under the same roof. Patients really do like that. They don't like to be having to jump around from different places. And he thinks there should be more integration to meet patients' needs. And lastly, he talks about expanding across delivery systems. When I travel across the country, there is one healthcare provider group that I always see in every single city I go to that has exactly expanded across geography. Anybody know who this is? I mentioned them earlier. Pharmacy. CVS, Walgreens, Rite Aid, basically in every city I go to. They've pushed out the community pharmacists. They basically don't exist anymore. They've expanded what they do across regions, nationally now. And Cleveland Clinic is doing the same thing. They're building hospitals, I think, overseas. UPMC, that I mentioned earlier, is providing management services to hospitals in the UK. They are taking their knowledge and selling it to other folks across a broader geography because they have this specialized knowledge. He says there should be more of it, that we should move from sort of the cottage industry we have in healthcare, where you have a lot of small providers, and those services should be broadened because there's going to be more expertise that can be across a larger area. I don't know if that's the reason for it, but I know that when providers consolidate, they have more market power. I know in healthcare today, the regulatory impact is so high that a lot of small providers just can't deal with the additional regulations. The fraud and abuse risks are too much for many organizations, and they would much rather be part of a larger organization or contract something out that doesn't relate to direct patient care. There are lots of reasons why providers might want to sort of grow in size and expand across geography. So, from the value-based perspective, ask yourself, what can I sell to my HMO or my MCO that I offer more value to them than they can get from somebody else or they can get from one of my peers? Do you have higher medical adherence ratios for prescription drugs? Do you reduce inpatient hospitalizations and ER visits? Can you quantify it? Can you reduce the total cost of care? Because that's what they care about. I can tell you right now that if you go to a plan and your argument is, I should get paid more because my costs are more than what you want to propose to pay me, that's not a winning argument. You might as well not even waste the time. But if you can go to a plan and say, if you pay me in this manner or this much, and you contract with me, I will save you money, now you have a start of a conversation. Because now you're on the same page as that plan. Your interests are aligned. But if you don't do that, and you don't have that discussion, you're not creating that leverage that you need to get a better rate. Now, I know many of you won't have data right now and are not in a position to do it. You may know your own clinical data very well because you may have had to report it, but that's not enough. It needs to be linked to dollars and cents. So that means you need to access data. That will require some effort on your part, either through networks, where a network can access data from a payer and obtain it so they monitor the total cost of care. It might mean new affiliations with hospitals so they provide you real-time information. It might require some additional meetings with the plans to persuade them that the confidentiality laws don't block them from providing this data to you, because I've heard that argument before as well. Question here first. On this side, there was a question first. Yes?
Just a quick question. Are plans going to be required to change how they set up their fees? Because right now, plans have a fee schedule. There is no negotiating. You get a piece of paper and it lists all these codes and all their fees, and you can't. They won't change that. So is that something that's going to be changing so that providers have some sort of way to negotiate a rate for, say, a group or an individual's like therapy session or something like that based on the amount of time? Because right now it's not built into a contract. They don't do that.
So the question is, right now, we can't negotiate rates.
Right.
It's all fee for service. Do you know that there are some providers that negotiate rates? Would it surprise you that there are some providers that actually negotiate fee for service rates? Or if they're paid on a percentage of Medicare or Medicaid, negotiate what that percentage is? You may not be receiving and being able to negotiate rates, but there are other providers that do. Think of some of the large institutional providers as well, like the hospitals. Do you think they just accept what the plan offers in the first round? Don't kid yourself. Those that actually have leverage in those discussions can negotiate rates. I've been at the table where small safety net providers have negotiated rates because they were needed in the network by the plan, and they got a bump in payment. I've been on the side of the plan representing when these providers started these plans, and I've seen how we've paid certain providers more in order to get them to agree to participate in the plan. So there are providers out there that do negotiate those fee-for-service rates. And moreover, the RFQ, it doesn't prevent you from negotiating a capitated rate, a shared savings model, a pay-for-performance model. There is specific language in this RFQ that says plans can, even in the first 24 months, pay you differently. Do they have to get approval from the state? Absolutely, they have to get their approval. But it's not prohibited. There's a lot of flexibility. Now, they may not want to initially as they're running around setting rates. They may want to pay you on a fee-for-service basis. So you'd have to persuade them that paying you differently actually will help them in the first couple years. But there are providers who are negotiating rates, and because they have the leverage to do so. You don't have to accept and sign every contract. And a question back here. Yes, sir.
So where's the safety net? Or maybe you said this already. So as you're negotiating rates and people are coming up with ideas, what ensures the standards and the quality? Because, I can negotiate and try to come up with a way to get a better deal, but I'm ensuring the quality of the services or the patient care. And is there some way to make sure both are occurring?
In your provider contracts, and we'll talk about this, the question was, how do I ensure, is this from the plan perspective or the provider's perspective? From the plan perspective, how do I ensure that I'm not just negotiating a lower price, but actually maintaining the standard of care delivered? Or how am I, a provider, ensuring that I get paid adequately so it doesn't take away from the level of care I'm providing? The contract has a lot of protections for quality of care. There's a lot of language in here that you probably wouldn't find in your commercial contracts that relate to how decisions of medical necessity are made, decisions of utilization review. Do you know that the plans actually have a withhold from their premium payments from the state starting in year 2 of 1%? That means a reduction in their premium dollar by 1%. And these are multi-million-dollar contracts, so we're talking about a lot of money. In year 2, that bumps up to 2%. In year 3 and 4, that moves to 3%. That's a reduction in their premium that they have to earn back. How? By performing well on clinical performance standards. So there are state incentives. I mean, I'm not saying that they're 100% adequate, but there's an effort by the state to try to ensure that the clinical care is not compromised by the plans in the discussion.
And usually where the actual patient has to weigh in some way, shape, or form about the quality of service or the plan.
The question was, how does the patient weigh in? The patient weighs in if you collect the data. If you have a system where you collect information from the patient, or you're under a system that requires you to have interviews with the patients, sort of like how hospital discharges, there's a survey, a CAP survey, that goes out to those patients to measure their satisfaction of the care. There's a lot of surveys and quality information out there and systems out there. In fact, they're probably overlapping, multiple, and inconsistent with each other. But there are a lot of groups that collect that kind of data. And the state, I'm sure, would like to see some of that data as well so they can ensure patient satisfaction. Many of you are looking at integrated healthcare models where you've aligned yourself perhaps with a primary care provider, because there is a huge push, not just in New York State, but across the country, for pushing primary care and behavioral health together. You know, in the state of New York, that the costs for folks that have comorbidities, chronic conditions, and behavioral health conditions are high. And their physical health concerns are really what accounts for those high costs. It's not the behavioral health services, it's the physical health conditions. And despite those higher amounts being paid, regardless of those higher amounts being paid for this population, patients with behavioral health and physical health conditions die 25 years earlier on average. That's a real embarrassment, despite all that money that goes towards that population. And it's because the full needs of that patient are not being dealt with. So do you have a connection with a primary care provider? Have you leased capacity from a primary care provider? Have you hired primary care providers? Are you going over to primary care providers to provide your specialized services? Many providers are looking at these types of arrangements because they can then go to a plan and say, I have these types of arrangements. I'm giving you better value because we also have systems to monitor the patient's physical health conditions, and we make sure that they get referrals over to primary care providers. We interact with them much more, and we make sure that the discharge planning, appropriate discharge planning, takes place, because otherwise it doesn't occur. Or we do care management or case management for these patients, and it's not limited to their behavioral health conditions, but it actually is broader and relates to many of their physical health chronic conditions. This is more valuable to a plan than somebody who does an isolated service. That's an advantage that these integrated providers bring to a plan. That gives you additional ability to compete on value. And the last part is whether you could incur some downside risk. I have some primary care providers here in New York State. They negotiated a capitated payment from plans for primary care services. What that means is they get a PMPM to cover the primary care services for that defined population of patients, and they're assigned through some mechanism decided by the plan and the provider. And if the patients have more utilization, it's on the provider's shoulders. Plan doesn't pay anymore. They pay that PMPM, and that's all they pay. Is that good for the plan? Absolutely. That saves the plan money. They have downstreamed some financial risk, maybe not a lot because it's primary care, to the provider. So many of these like these arrangements. What kind of payment arrangements can you have with a plan where they are downstreaming some of their risk to you? Is there a bundling that can occur for any of the services that you provide? Is your service offering broad enough so that you can actually take a capitated rate that encompasses a broader range of services? Do you need to pair up with other providers through a network or some other device so that you can take a larger capitation rate that relate to both primary and behavioral health services? I know it can be done. In the state of Colorado, where the behavioral health centers have BHOs, behavioral health organizations, and these BHOs pay for all the behavioral health services in the state of Colorado. There's separate regions, 5 or 6 of them, I think. It's all done on a capitated basis. Each of these BHOs gets a capitated rate from the Medicaid agency. They've done it, and then they decide as a BHO how to pay those underlying providers. Some of them can be paid fee-for-service, some of them can be paid capitation. It's really up to the BHO to decide. They've done it for behavioral health. It doesn't just occur in primary care. Are there mechanisms to achieve shared savings programs? You know, you don't need an ACO in the middle between a plan and a provider to have a shared savings arrangement. There are many providers out there that directly go to a plan and say, we want to be at risk for the total cost of care. We're willing to share these savings with you. We only want upside risk, so if it costs more for that population, we don't want to incur the downside risk, but we want the potential upside. And if we have that upside shared savings risk, we will invest in making sure that we can reduce some of those costs because now we have a financial incentive. Many plans want you to have that same financial incentive of reducing total costs of care. That is perfectly aligned with their objective. And making providers benefit from it, that helps them out. And you don't need an ACO in the middle. You don't really need a network in the middle. Unless you're moving to downside risk, I don't see the point. If you are large enough to have a population of patients where you can spread that risk over for the total cost of care, it makes a lot of sense for a large provider to have a shared savings agreement. I used to play these games, so when I get a contract review from a provider, and it starts out just having the fee-for-service rates that the gentleman mentioned earlier, I say to the provider, any interest in proposing a pay-for-performance program? Sure. Any interest in proposing shared savings? Okay. And so I return the contract to the plan. It has fee-for-service schedule. We might have modified and tinkered with that. Pay-for-performance bump, shared savings bump, and we send it to the plan. And what do you think happens? They don't always just scratch off those shared savings pay-for-performance parts. I had one recently. They took off the shared savings, but they left in the pay-for-performance dollars if certain clinical measures were kept. The provider, simply by asking for it, got more than they would have received if they had just signed the contract to begin with. Why leave dollars on the table? Why not drive the bus and actually ask for what you want and see what the response is? Of course, if you can couple it with data and a value-based argument, all the more likely it's going to be accepted. But if the plan has to reach clinical benchmarks in order to recoup that lost 1%, 2%, and 3%, and you can help them reach it, shouldn't you be entitled to some of that money as well? You did the work. Why aren't they sharing it with you? Maybe you didn't ask. So now you're making money for the plans, and you're not getting a share of that money? That doesn't make any sense either. You're their partner. You're making it possible. In fact, maybe a plan will invest in you or front some money to you or your ACO so that you do these activities so they can recoup those millions of dollars that will be withheld from their payments. But how many of you know about those premium reductions? How many of you know about the performance projects that they're going to have to do well on and the clinical measures that is going to be a basis for whether they recoup those dollars? You should. That information arms you with the knowledge you need to obtain a better contract. The last piece is communicating the value that you provide. Think about it when you go into a store to buy toothpaste. Aren't you confronted with a dizzying range of options to choose from? All sorts of different brands touting different things. And really, all you're buying is toothpaste. For goodness sake, it's just, paste for your teeth. But you know, don't you, that some toothpaste is for folks with sensitive teeth. Some is for people who have gingivitis. Some is for folks who want to whiten their teeth. Oh, there's all these other factors I can choose from. And how do you know about that as a consumer? Because of the advertising and the marketing messages. Otherwise, you'd be thinking that everybody has the same product. But because you've received that communication from a provider of services or supplier, in this case the toothpaste manufacturers, you know that you can evaluate different toothpastes against each other. And you might even pay a little bit more for that toothpaste that has the whitening in it than you would for one that doesn't, right? I know some of us do. So in the same way that the plans currently look at you as all providing the same service within your service type, it doesn't do much for you as a provider at all. And that's how they look at you. I know that the plans have, these are their contacts for primary care providers. These are the contracts for specialists. These are the ones for hospitals. These are the ones for behavioral health. They are all separated in separate contracts. And their model contract will include that same basic pricing for everybody. And they don't see any reason to pace anybody differently because everybody does the same thing from their perspective. Or do you? Do you really all provide the same level of service? The same quality service? Or are some of you maybe better than others on certain factors? Are there some reasons where you do provide better value and you should get paid more? Are you more the Cadillac of your type of provider? And can you demonstrate it? Can you give the plans a reason to pay you more than they pay Joe's shop down the street? So how do you do that? When I did the last training in Rochester, somebody came up to me because she had heard me before at a prior training, and she said, "You know what we did recently?" I said, "What?" She said, "We created marketing materials." And I said, "For your patient?" She said, "No, for the plans. We actually now have marketing materials that we send out to the plans that describes our scope of services because they don't know what we provide. And we tout our accreditation and our clinical performance and all these other factors because we want them to see us differently, in a different light than the other providers we actually compete with." In the RFQ, the plans are required to have a clinical director, a medical director for behavioral health, a clinical director for behavioral health. These are clinicians that probably share a lot of the same concerns and interests that you do in the room. There is no reason why you can't reach out to these individuals and want to participate in the plan's performance improvement projects, the plan's quality assurance projects, and shape those so that they're designed where you do well or where you need the support. Why aren't your folks meeting with their folks? There's a natural alliance there. You should attend the same conferences and presentations so that you make that connection. These relationships take work, just like any customer relationship. It takes work and conversation. So we need to do a better job of making those connections with the plan so that you know these people on a first-name basis. It'll break down some of the barriers, some of the hurdles, and start having those discussions. Now, I'm not Pollyannish. I know that not all of those folks will want to meet with you. Maybe there's only one plan out there. But you know what? That one plan is better than no plan at all. Start small. You don't have to move to 0 to 60 in one leap. You can move gradually. Think about what plan among all the plans that serve your county are most likely to be open to speaking to providers. Sometimes this is maybe if there is a provider-sponsored plan, sometimes this is a nonprofit plan, sometimes this is one that just touts itself. I saw an ad in the newspaper yesterday by Optum touting itself about the benefits. Well, let's see. Reach out to the ones that claim that they are really concerned about patient care and see whether they are truly open to having this discussion. These are multi-million-dollar contracts with the state. I don't think they'd like it too much if the state heard that they weren't willing to meet with you. or sit down with you. Because the state certainly has an interest in them doing that and sitting down with you and finding ways to collaborate. That's how this model is supposed to work. Last, if you're not happy with the value you have today and you want to increase your leverage, this is the time to start thinking about the types of collaborations that need to occur in the next 24 months. The first one is if you don't have an integrated care model, you should start doing it. There are a number of primary care providers that are crying out there for additional behavioral health capacity. They just don't have it. They don't have the expertise or they don't have the people. And they are happy to contract and lease your people for a certain amount of time. Some of them really have moved to an integrated model where a patient, if they come in and the doctor thinks a behavioral health intervention would help, then they have a person right there and they go meet with the patient. And some of the payment systems for some providers support that, and they can bill an additional visit to the payer for that service. It makes financial sense, and it's an example of the financial system, the payment system, supporting that integrated care practice. If you are a behavioral health provider, you should think about how the primary care needs of your patients are being met. Maybe you can think about some kind of joint venture. And there's a whole range of options there. I'm not advocating that you merge with a primary care provider and lose your identity. That's not what I'm saying. You can do a lot less than that. You can have a co-location, a referral agreement, where you just have a formal in-writing referral agreement where patients are being referred back and forth. You can look to a co-location model where both providers are on the same campus. I see that model common. And then maybe if that works out, you might think about some kind of formal merger. But I would never say move to a merger immediately. One of our clients wanted to move to a merger, and just because of timing issues, they decided to do a contract for an interim period of time where they just contracted with this other provider for integrated care. They were very glad they did because the marriage wouldn't have worked out. Think of contracting sort of as dating, trying to see how it might work out, see how it works, and you know what? Sometimes it doesn't, and it's glad you didn't go ahead and get married. So think about these arrangements because this adds value to the arguments you can make. And there's a range of legal models out there, joint ventures where you simply have contractual ties with another party, partial integration where you create a separate legal entity, just like some of these PPS systems. The hospitals have actually created a separate legal entity, often an LLC, but also sometimes a nonprofit organization as a result because they wanted to have that serve as a vehicle for the PPS. And then the last model is full integration. But you don't even see full integration with plans in every type of what we think of an integrated care plan. If any of you are familiar with Kaiser Permanente, do you know that there's no actual legal entity called Kaiser Permanente? It's their trade name. There's actually two legal entities in every market they serve: Kaiser Foundation Health Plan and the Permanente Medical Group. And the reason why I know that is because I used to represent them along with some other similar staff and group model HMOs. And in Washington, D.C., they have two lobbyists, one for the Permanente Federation, the Federation of Permanente for-profit medical groups that contract exclusively with the plans in each of their regions, and then the plan lobbyist. Usually they're on the same side, but sometimes their interests diverge, and they have different priorities. So there's, even where we think there's integration, there's not always integration. But the plan, and like a Kaiser plan, they actually invest huge amounts of dollars in their providers. Of course, they're exclusive there, so they have a reason for doing so, and they support the provider's work because from the plan perspective, it saves them money in the long run. And then the plan actually owns the hospital systems. It's a separate legal entity, but the plan controls it. Do you think they want to use hospital services? No, of course not. That accounts for the greatest costs in care. They would much rather funnel it to primary care providers to prevent those hospitalizations. In fact, if you look at how care is spent in this country and you compare the amount of primary care to hospital services, you'll see a huge gap. If you look at behavioral health spending, you'll see an even bigger gap. Even though the behavioral health community as a whole keeps most of the dollars allocated for behavioral health, it's a very small portion of total healthcare expenditures. So many folks are looking to join other folks in some sort of network. You've probably heard of IPAs in the past, independent practice associations. There's a large alphabet soup array of these types of networks. BHOs, behavioral health organizations that have a group of providers working together, MSOs, groups of providers working together in order to achieve a common interest. I just received a contract from an MSO, which is going to be operating a Medicare shared savings program on behalf of a group of providers. They formed it together, but they didn't feel they have the expertise to operate an ACO, so they hired an MSO to provide that knowledge. They have the IT support. They're going to do the analytics on their behalf. And then if there's shared savings, they split a little bit with the MCO, and then they keep the bulk of the savings for themselves and distribute it. If you come together, and this goes back to the question earlier, if you come together and you want to work with other providers, what you have to recognize is that this is what triggers the antitrust laws, because the law considers you, each of you, competitors of each other if you overlap in geography and service. The cute cartoon says, give me one good reason we shouldn't promote teamwork. The government calls it antitrust. Yeah, the antitrust laws prohibit any restraint on competition. That bars all contracts, conspiracies that restrain competition. Now, there's actually one line in the Sherman Act, and you know, actually, that that's not possible. That all contracts that restrain competition are prohibited. What about that contract you have with that practitioner? You employ them by contract full-time. They can't work for anybody else. That's a restraint on competition. Why isn't that illegal? Well, the Supreme Court weighed in a very long time ago and said, yeah, Congress couldn't have meant what they said here. And they must have meant all unreasonable contracts and conspiracies that restrain trade. And then over the last 100 years, courts have interpreted what unreasonable means, because as you and I know, unreasonable is one of those legal words that doesn't really have much objective meaning. What's a reasonable person standard? I don't know. What's a reasonable person? Are there reasonable people out there? So the courts have identified what's not reasonable, and one of the things they've said is not reasonable is when providers fix prices. The same way you don't like the airlines coming together and fixing fares, or the gas stations fixing fares, you want competition to occur. You don't want them talking about how much they're going to be charging you as consumers, because you know when that happens, it often leads to higher prices. So the antitrust laws through the courts have said whenever providers talk about how much they're going to charge the consumers, that has no pro-competitive benefit. We're going to say that they should be illegal. We're not even going to look at if some of that cooperation has helped to improve costs, improve care, or lower costs. We are just going to assume and deem the contacts prohibited under the antitrust laws. So how do these networks actually negotiate? In 1996, the FTC and DOJ, after a barrage of criticism from the industry, where the industry felt they had no clear guidance from the agencies about what they could do and what they couldn't do collectively when networks were being pushed, the DOJ and FTC issued guidance. And they said, you know what, these networks, you can do negotiation. We will not prosecute you if you fall into one of our safety zones. Safety zones are like safe harbors that you might have heard under the kickback statute or exceptions under the Stark Law. They are a protected place. You fall within the safety zone, you're safe. And what does the safety zone say? It says if the network is sharing substantial financial risk together, then they can negotiate the amount the network is paid with the plan. So those networks that are actually negotiating fees with the plans, it's really, in most cases, not a fee. They're receiving capitated payments from the plan. And the reason why they can negotiate is because by sharing those capitated payments, by being beholden to them, they are sharing significant financial risk, because the providers that participate in those networks know if that network doesn't get enough money and it runs out of money because we have more utilization, it's not the plan that takes a dive, it's the network. And that's how the antitrust enforcement agencies look at it as well. Now the interests of the providers in that network, they're aligned. And it helps consumers because now there's an incentive that drives down costs and potentially improves quality of care. So those networks out there, if they're negotiating price, it's most likely because they have some sort of capitated arrangement. Now, there are some providers out there recently that want to participate in a shared savings program collectively. And they've actually bifurcated the process. So they've retained their contracts that they have individually with the plan so they can negotiate rates, and then they've come together simply to negotiate a shared savings arrangement. That is, if they perform collectively well, below the benchmark that's established for the total cost of care, the network earns an amount, and they share it with the providers. The network can negotiate the shared savings rate whether it's 60-40 split, 50-50 split with the plan. Why? Because now they're sharing financial risk for the total cost of care. Their interests are aligned together. They either all do well together or they all fail together, but their interests are aligned. Antitrust laws would permit that in that situation. Yes, ma'am.
Do the antitrust laws pertain to all of the other provisions other than the rate negotiations? So could you have a shared interest in negotiating the credentialing standards or the standards of care but not negotiate the rate, or is it not separate? Can it not be separated?
So the question is, because the microphone might not pick it up and this is being recorded today, is can you negotiate other aspects of the contract that don't actually deal with the payment terms, like credentialing practices and so forth? And the answer is yes. If it has no payment implications, if it's not considered a payment-related term, yeah, you could work to collectively on that on those terms. The laws wouldn't prohibit it, but most providers don't want to come together to do that kind of work unless there's a dividend related to payment. It's just not enough. They feel we can do it on our own in that sense. But yeah, theoretically, you could come together. In fact, there's nothing that would stop a network of providers coming together and the network looking at these contracts, like the gentleman mentioned earlier, and coming up with the business terms for those, so sort of a summary of business terms in that contract, and then providing it to each of the providers in the network. What couldn't happen is the network providers can't discuss those terms together. They can't say, oh, this is good or bad for us. Let's do this together. They can't decide together whether they want all to be in or all to be out, because that would be a kind of price fixing. If they all decided to be out together, that kind of boycott the plan unless they raise our rates, that's a type of unreasonable restraint on trade. In fact, the lawyers got in trouble for that a number of years ago in D.C. The lawyers that provide legal services for the indigent, they felt they weren't getting enough from the courts. So they decided to boycott the courts. They said, if you don't pay us more, we're not going to participate. And then the court sued them, and they lost. Because in that case, they were boycotting a payer collectively, and they were all independent competitors of each other, and they couldn't do that under the law. So you have to be very careful when you work together so that you're not aggregating your market power in that way, because you can't do that unless you meet the safe harbor where you are significantly sharing that financial risk. This is a sea change for many providers because many of you are used to negotiating and talking about payment terms collectively. In fact, some of you might have actually even talked about some of the payment terms about how much you're getting paid by the plans, but you shouldn't do that. You can do that with the state when the state is proposing payment terms. And why can you do that with the state? Why can you collectively negotiate with the state through your associations? Because you have something that trumps the antitrust laws, and it's called the First Amendment. You can petition the government. And the Medicaid agency, or OMH, or OASAS, they are the government. You can collectively negotiate with the federal government, state government, county government, any government collectively. But once you move into managed care where there are private firms, that changes. It's a whole new ballgame. The law views you now as competitors, competing firms against each other. Yes, sir.
Suppose one of your partners is a state facility. How does the fact that they don't really share in the same financial risk, the same way that you would enter into this?
Question is, what if one of the providers in the network is a state or government kind of facility? Does that change the analysis? Unfortunately, it doesn't, because the negotiations is not with that state provider. The negotiations is with the managed care entity about how much you as collectively as a group are getting paid. Now, that independent state facilities, usually county or government-owned facilities, they in many cases can just set the rates of how much they want to get paid because they use the law to do that. They don't use a market mechanism. But in the context of managed care, where you have providers that are supposed to negotiate rates independently, that's a market-based mechanism. And the mere fact that you have a government participant in those discussions is not going to change it. It only helps the government, let's say if you're a jail, for example, and you want to hire a firm to manage the mental health services. Yes, you can do an RFP, and it can be a competitive process, and you can ultimately decide how much you want to pay any particular vendor, but you know those vendors, they can't actually discuss what their bids are. That would be a price fixing, a bid rigging violation. So the government has certain advantages because of their ability to impose prices, but merely because they're a participant in a free market system does not give them that immunity. What I thought you were going to ask is what happens if you have a group of providers in a state, but they all serve dispersed geographic regions? They are not competitors. Can they come together and negotiate price? And the answer is yes. Only if they're a competitor of each other does the law forbid them from jointly negotiating price, because the reason is there's no loss to competition if they start talking about price and agree upon a common fee schedule, because they weren't competing in the beginning, in the first instance. So there are examples of providers and entities across the country that have formed a network to help negotiate prices because they're all separate from each other. Now, have they been careful to analyze how those markets are defined? Absolutely. Their lawyer said, you better have some documentation to support the fact that you are not competitors under the law. And recently I found out that the Dartmouth Atlas actually has primary care service area definitions. That's fantastic. They tracked where patients go, where Medicare patients go, to receive primary care services. And then they formed these geographic regions based on that knowledge. So it wasn't county-based. In fact, I think it got down to the census level. And these formed these areas. Well, providers in those states, if they know that they serve separate primary care service areas, they could collectively negotiate price. And they have good objective data to back that up. There was a question earlier.
So just going back to one of your very early slides, where in the RFQ, the state-operated inpatient psychiatric hospitals have a different standard for mandating their participation in the network than the community-based providers. How is that not a violation of antitrust, that they've set a different rule for themselves when they themselves are setting the rule?
That's a prerogative of the government. When they write the contracts, they can give certain advantages. Now, they don't always give it to public entities. I mean, as I mentioned, my example earlier in D.C., where they gave 15 safety net providers a guaranteed rate and guaranteed contracts, those were all private entities. So they can do preferential treatment for whomever they want. But in that case, obviously, they did it because it's a public entity. Yes?
So as a not-for-profit, I recently began discussions with a local health plan. And they asked us one question related to cost, and that is, what is your cost? Because they'll pay us what our cost is. So where's the negotiation come in?
I want a contract with that plan. The question was, a plan came to us, and they asked us what our costs were, and they want to pay us cost. That's rarely heard. The reason is because we used to have cost reimbursement in this country, and then it went out of fashion because you have no incentive to control costs, and our costs kept going up in healthcare, and people said, oh, a cost reimbursement environment, that's not good. And actually, what many entities have realized is that it's not good for them either. It may be great to get your costs paid today, but what happens if you're trying to build a margin so that you can invest in your facilities for costs that you don't have today? Many providers say, this isn't a good system for us because we can't get that margin, get that capital that we need to invest in the future.
But if we're not-for-profit and we're partially funded by the state, we can't make any more than what our cost, than we have.
I think you're mistaken. As a not-for-profit entity, you can have a margin. It's how you use those dollars. Look at Kaiser Foundation Health Plan, a not-for-profit health plan with about $1 billion margin every year. They can use that for any of their nonprofit purposes. I'm sure there's other nonprofit providers in your communities, whether they're behavioral health, FQHCs, or whatnot. If they have a margin, that's not illegal. In fact, there's a guy named, I think, Dan Peretta, who does some amazing TED Talks about the nonprofit industry, the nonprofit sector, and he says, his thesis is that we shoot ourselves in the foot because we don't invest enough in ourselves. We don't find business models where we can develop a margin, and then we don't have capital like the for-profit entities do to invest in ourselves. Because there's this myth that we can't have a margin, or we sell our services in a way where we don't get that margin. So the answer to your question is, you can have a margin. And if a plan is coming to you to ask you your cost, you know what the other problem is for most providers? Is they do not know what their cost is. How many of you know what your costs are on a sort of fee-for-service basis? Do you actually compare your rates that are proposed by the plans to your costs? I see some head shaking because I know that we haven't had to do that. We haven't had to sort of figure out our costs on that level. We may know our costs in the aggregate, but we don't know our costs on the individual way that we're paid. We haven't done that homework. So financial risk, sharing a financial risk gets you under this safety zone. There are some limitations, of course, because the government always has limitations. If you're more than 20 or 30% of the market for your service, the government says you fall out of the safety zone. They actually say if you're a non-exclusive network, you can have up to 30% of market share. What does that mean? A non-exclusive network means if the plan gets fed up about the rates that you want, the rates that you want, they can go and pick off your providers individually that participate in the network because the providers are not exclusive to it. The providers can contract individually on their own. That weakens the power of the network, right? Because if your providers can contract individually with a plan, and the plan can go to one of them and say, we'll pay you more than we're willing to pay you as part of this network, then you can leave the network and contract individually. It weakens the power of the network. So the government says that type of network, a non-exclusive network, can have up to 30% market share. If you have an exclusive network where that can't happen, you can only have up to 20% market share. But in many cases, providers don't have that much market power to begin with. And many of them fall under this safety zone, or many of them decide, regardless of the amount of market share, because we integrate financially and we share that financial risk, it's good enough to protect us, and they feel comfortable with the amount of risk they're taking. So some of you might not be willing to share financial risk with others because you don't know each other. You've never worked with each other. You may be peers in the community, peers or members of a similar association, but you don't actually want to take financial risk immediately with each other. And I don't blame you because you haven't had to rely on each other. Many providers in this situation have looked at clinical integration models where the government says if you are clinically integrated, and many times they say that means a common EHR, common clinical protocols, you are effectively operating as a single unit clinically, then the government says you fall into sort of the safety zone under our rule of reason analysis, that is that balancing test about whether the pro-competitive benefits outweigh the anti-competitive ones, and you can proceed because under clinical integration, quality will go up, cost will go down. The problem, of course, is how much clinical integration? And because the government has such a squishy standard, that's a legal term, squishy standard, anybody that's proposing a clinical integration model actually goes to the government and asks, is this enough? So the government issues these advisory opinions. And they've done it several times over the years. A network has come and said, this is our clinical integration model. Is it enough to negotiate fee-for-service contracts? And the government has said yay or nay. And then they get the comfort they need from a legal point of view, and then they move on. But being clinically integrated costs a lot of money. Many people realize once they have to have a common EHR that's talking to each other, build common clinical protocols, kick out providers that are not adhering to those protocols, at that point they say, well, why don't we just become financially integrated because we're putting all this capital into this enterprise anyways and avoid the clinical integration uncertainties. So some do that. The newest and latest safety zone on the market is from the Affordable Care Act, created under the Medicare Shared Savings Program. And the fascinating thing about this safety zone is it has nothing to do with participation in the Medicare program. This safety zone applies to any ACO that is an active participant in the Medicare Shared Savings Program. And what that safety zone says is that by virtue of participating in the CMS program, that network can negotiate fee-for-service contracts with commercial payers. Well, that doesn't make any sense after what I've just said. You mean these networks that are not clinically integrated and not sharing financial risks because the Medicare ACO program, that's just shared savings. It's not a capitated program. Suddenly have this safety zone in their hands and they can negotiate fee-for-service contracts? That can't be. Yes, it can. If you meet their test for this safety zone, and it is a little bit of a four-part complicated test, but once you meet that test, you can negotiate fee-for-service contracts. And the reason is because the agency said to themselves, the CMS regulatory requirements for the Medicare Shared Savings Program are pretty stringent. They do require a lot of that investment. And we believe that those ACOs in the program probably are largely clinically integrated to a good extent. And they have enough financial integration, enough incentives to cooperate with each other that we're going to allow them to negotiate collectively with commercial contracts so long as all the benefits that they accrue on the Medicare patients accrue for the commercial population. That is all the work that they're doing for their Medicare population. They better be doing all of that on the commercial side too, so that that population also benefits from the integration and the accountability for that patient population. I know a few Medicare ACOs that only went into the Medicare program because they wanted the ability to negotiate fee-for-service contracts on the commercial side. All right, what do you do if you're not integrated and have no desire to be? If you're non-integrated, the only model left for you, and this may be the first model you think about before doing anything that involves integration, is called the messenger model. So think of a guy with a messenger bag. Maybe not a big box like the guy on the slide. And he's a messenger. The plan offers the contract to the network messenger. The messenger messages that plan out to all the providers. The providers independently decide whether they want to accept the plan's term or not. They communicate that message back to the network, and the network communicates that back to the plan. For those that are visually oriented, this is sort of a model of what it would look like, where you have a messenger, which is the network in the center. They have relationships with all the providers, A through F. MCO starts with the offer, and then they hear back from the messenger which of the providers accept the terms of the offer. Now, many of these messenger models have signing authority, signature authority on behalf of the providers because the provider has a contract with the network. And it says if the provider agrees and accepts the terms offered by the MCO, that the network can sign on behalf of that provider to the network. So the plan benefits. They sign a single contract with the network. It includes only the providers that have said yes to the plan's term, and it's more efficient for the plan. And the providers benefit as well because now they have a contract. Maybe they wouldn't have had that contract, but they can't negotiate the terms. The providers don't negotiate the terms in this model, nor does the messenger. That would be prohibited. There's a deviation on the model, which is called the modified messenger model. Imagine a survey. The messenger surveys each of the providers. What is the minimum amount you are willing to be paid under the contract? Okay, got it. Now, those providers can't share that information. The messenger can't disclose all the providers' results of the survey to each of the providers because you can't tell another provider what that minimum is that you're being willing to accept because that could lead to collective price setting. Then when the plan says we're going to pay X to the network, the messenger can respond, well, at that price, you can obtain 60% of the network participants. The plan says, oh, that's not high enough. I'll offer more. What if I offer X dollars? Oh, now you have 85% of the network. Something along those lines, where the messenger simply is not negotiating. They're just using the information that's been provided to them previously by the providers. That can work as well.
So what is this messenger? What is it?
So the messenger is a network. It's an entity. It can be whatever you want it to be, but it can be a consultant that's hired. But all they're doing is simply messaging the contracts. The question was, what is this messenger? A messenger is some third party which is operating as that messenger, that go-between between the plans and the providers. So you're probably wondering, well, what the heck is the advantage there if they can't negotiate? Well, recently we had a network operate under the messenger model, and they got a bump in payments. And the reason why they got a bump is because their contracts were so out of date with that plan. It was a Blue Cross plan. They had not received any fee-for-service bump in a number of years, and by simply operating under the messenger model and getting the latest contract, they got a bump in rates. Are there risks and downsides? Yeah. If you go over the line, if you find out that the providers that are in that model are now talking with each other about whether the terms are good, it doesn't adhere to the messenger model, and you're exposed under the antitrust laws. When I worked with the division, we went around the country, and we blew up IPAs who had said that they were operating under either clinical integration or a messenger model, and what did we discover? They weren't. Like in western North Carolina, in the Asheville area, all the providers had joined the same IPA, and the plan was paying something like 30 or 40% more in that area of the state than in the other parts of the state. And it was because of the aggregated IPA power of Mountain Healthcare, which was the IPA, and we blew them up because we found that they were not clinically integrated, and they were collectively setting the fee schedule. So when the plan wanted to contract with them, they told them what the fee schedule was that had been decided by the providers working together, and they got it because the plan had no choice but to contract with that IPA. Any benefit for the patient? No. Benefit for the providers? Absolutely. They got to jump in rates. From a competition point of view, nothing good. Doesn't save the plan money, not good for quality of care from a market perspective, doesn't do anything for competition's sake. No, not good for cost or quality. If you're not ready to jump into a messenger model or managed care contracting with other providers, you may want to think about doing something more limited. Many of the networks that I work with that are now doing managed care contracting didn't start there. They started from a shared services network where there were certain things, back office stuff, they didn't want to do on their own. They didn't have the resources, they didn't have the expertise, they didn't have the money to fund it. And so they pulled their dollars together. They hired, one EMR vendor with one EMR supporting all of them, group supporting all of them. Or they didn't want to do their own billing because they didn't have the expertise and they were concerned about the fraud risks, and they hired a separate billing agent. But they created the company to do that. They created a network called a shared services network, and then that network either performed those services in-house for everybody or contracted for the expertise individually with partners, but all the providers participating in the network, shared the cost in that. They were billed at cost by the network. And then after they got comfortable with working with their peers in that kind of model, then and only then did they consider moving to a managed care network model where the entity network was actually performing some of those tasks. There was a question up front, I thought, earlier. No? Okay. This is a really good stopping point. It's about 11 to 25 now. Let's take a 15-minute break and come back for the next part.